So, hi, Dr. Ben Malcolm. Nice to see you here today. Dr. Ben is a doctor of pharmacy, master of public health, and board certified psychiatric pharmacist. You do amazing work to support people in the psychedelic space with your wonderful training, and it's really helpful. So I'd really like to get in and have a chat with you, because I know you work with regular psychedelics generally, and we're talking a little bit more about cannabis today. And cannabis works predominantly on the 2G protein coupled receptors, GPCRs, CB1 and CB2 predominantly, and maybe other additional receptors may be involved. We don't know too much details. And I'm wondering, it's particularly focusing on any contraindications that may happen with cannabis. Now, of course, that's different to other serotonergic hallucinogenics like LSD, psilocybin, that work predominantly on the 5-HT2A receptors. So maybe you can just talk about the differences. Is there anything you know about cannabis, and is there any contraindications? Start there.
Yeah, that's it's a good place to start. I mean, I think generally there are both similarities and differences between cannabis and psychedelics. I think a lot of the times, actually, persons may not realize quite how similar cannabis, and particularly THC as a cannabinoid, can be to psychedelic experiences. Like, for example, when the state of Colorado first recreationally legalized marijuana or cannabis, they saw emergency department visits related to cannabis go up in triple-digit sort of numbers in that first year or a few after they legalized it. However, hospital admissions related to cannabis didn't budge at all. Right. So it's fairly clear that whatever is going on with persons in cannabis in that first year after the recreational legalization was not a physical sort of thing at all, but a lot of people showing up to the emergency department for psychological kinds of reasons, or essentially thinking that they're dying is a pretty common one. And man, if I had $1 for every time I heard the brownie at Red Rocks story about how I went to a dispensary, or maybe just got a brownie or other type of cannabis edible from a friend, and I was instructed just to take a teeny little bit of it because this thing is quite strong, and I took a little bit of it, and 30 or 40 minutes later, nothing was happening, and an hour and a half later, I felt a little something, so I just ate the rest of it at that point in time, and then I, had some kind of panic attack, and it usually is like in this kind of like, well, I don't know, usually, but the brownie at Red Rock story, at least, is always at the concert kind of environment where, it's a less controlled, lots of people, kind of like hyper-stimulating kind of environment. And then, the conclusion of the story is a little bit more like, so I never touched a cannabis edible again, because obviously cannabis edibles just have these sorts of adverse reactions to them. And I think, like, even within the medical community, there's like a sense of kind of like, okay, when I look up THC, or maybe I go to like the prescribing information for like Marinol or Dronabinol, like the pharmaceutical like Delta-9, like THC, and it will list the side effects, and it will say stuff like euphoria and dysphoria. And it's just kind of like, what other classes of substances have similar sorts of behaviors, right? Like, if you took that brownie at Red Rock story and just replaced cannabis edible with psilocybin mushrooms, people would be like, well, duh, that you shouldn't have psilocybin mushrooms in that kind of uncontrolled and chaotic kind of like setting, because there's a real chance that you are going to have this sort of difficult, challenging, or just bad type of trip. But when it's cannabis and THC, it seems like, oh, that's just an idiosyncratic kind of effect of the cannabinoids. And so I think it is true that at least THC is a type of psychedelic. I think of it as a psychedelic that has a tiny bit more volition than something like psilocybin. Like, if your phone rings and you've been using some cannabis, usually you're able to figure out that your phone is ringing and answer the phone. Whereas mushrooms, depending on how deep you are, you may not be able to do that, or it may just sort of seem like a completely overwhelming type of task to kind of be engaged in. So that wasn't really at a very molecular or like pharmacology level, the difference between activating a CB1 G protein couple receptor versus a serotonin 2A receptor. But I think it is inherently a little bit of an error to think of cannabis as the alcohol alternative. Like, because we see a sort of like cannabis legalization movement happening. And I feel like a lot of the time it's like, oh, well, this is really great because, if I'm smoking weed or using cannabis, then I'm, not drinking as much. And it's kind of like, okay, well, if you reduce your drinking, that is great, but I don't think it's an alcohol alternative per se. Like, I think the cannabis education, we would be wise to take a leaf out of psychedelic education and kind of talk a little bit more about set and setting, maybe. Yeah. Or maybe even ritual instead of habitual type of use patterns with cannabis, or treating it with more reverence instead of some cheap street walking alternative for alcohol or something of that nature. And truly, if you're somebody that enjoys cannabis, but you've never just taken a hit of cannabis and then sat with your eyes closed for 30 or 45 minutes afterwards, you've missed something with cannabis. Yeah, and I encourage you to try it like that. Yeah,
exactly. And obviously, you're in the US, so where it's legal, and you've had to go through these stages. In Australia, where we share cannabis psychedelics, it's a medicine, so it has to be prescribed by a doctor. And people, again, are just like sent home with their cannabis, and often they take it in those kind of forms. And the people who come to us and the people we're sharing with are using it only in a ritualistic form with a very controlled setting, who have gone through medical intake forms, who are laying down with their blindfold on and going through the full experience, as in the same way as probably someone would take psilocybin or MDMA, or not MDMA, but psilocybin or other psychedelics for an inward journey. So we've got that part covered. But it's more in the when you're looking at an intake form and people are saying, I'm on this drug and this drug and this drug and this drug and this drug, because they're coming with their trauma, they're coming with their issues. I guess we're mostly interested in, how do we look at those things? I mean, and with psilocybin, it's a little bit easier, or MDMA, to see, what the contraindications may be. And look, I know this is a very individualized question, and I'm not asking for one answer fits all. And if I read from one of your blogs, you've suggested some questions that a patient or a client should ask themselves, which is, they should be considering that stopping abruptly or tapering anything too quickly would always put you at risk of severe withdrawal symptoms. What are the benefits and side effects of my existing medication? What are my goals regarding the use of my medication? What is the compatibility between my current medications and planned psychedelics? And I guess that's more to the question that I'm trying to focus on. And do I have experience tapering and washing out my medications? Am I sensitive to withdrawal or experience extreme symptoms when not taking my medications? Is my provider supportive of our plan to taper me off? And of course, in Australia, at least, that's critical. We as facilitators and the client cannot make those decisions. It is up to the prescribing doctor or psychiatrist or whoever is, the actual prescriber of that medication. And will they help, step down those doses or manages with the withdrawal symptoms? And what is the support network that I have? Is it strong enough to get me through this taper and washout period? Is it a good time of my life overall to attempt to taper this and actually use psychedelics to get to more of the root cause of the issues? And am I potentially, am I okay with a potentially less intense subjective experience, or is an intention to have the most potent experience possible? So all these are wonderful questions that you've posed in one of your excellent blogs that, I'm sure our listeners will have take a good look at after. But again, is there anything we can offer people just to consider specifically in terms of current medications and a planned psychedelic? And I'm happy if you want to talk about psilocybin and MDMA as well, but I'm really trying to focus on cannabis. because
Are you talking about, so you're talking about like a cannabis assisted therapy type of
that's
modality
that's what we're offering. Yeah.
rather than regular or like daily use of
Correct. This has nothing to do with regular.
cannabis or cannabinoids?
Yeah.
Yeah.
And it's often for people who've had that Red Rock experience and haven't had
Yeah.
cannabis for 20 years and come to
Yeah.
us and said, actually, I'm willing to try it again in the safe setting that you have with your
Mhm.
nurses, doctors, psychiatrists, and support people around in a safe setting with particular medication, you know,
Yeah.
in a with my eye mask on, with the sound journey, with the attention setting before, and with the integration
Yeah.
setting you're offering after. That
Yeah.
whole feels safe for me, so I'm willing to try it. But I'm taking this, and this. Is that okay? So
Yeah.
how do we as facilitators get to look at this, and this, and go, yeah, that's okay,
Yeah.
not okay. We're not doctors, we're not nurses, we're not.
Yeah. So it's like an inhaled cannabis experience.
Yeah, vaporize using
Yeah.
vaporizing, in which is the quickest, cleanest form using the
Yeah.
German vaporizers. So,
Yeah.
mm.
Yeah. Well, I think the good news is, right, is that cannabinoids aren't going to be really toxic with very much. Like there's not really very many medications that I can think of. I'm struggling to think of one, honestly,
Okay.
that when you combine it with cannabis, all of a sudden cannabis becomes toxic or it makes the other medication really toxic, right? So I don't think that you're sort of thinking like, oh, there's some list of medications where if they use cannabis, then they're likely to suffer a severe sort of physical consequence or have a medical emergency like right there, purely from a drug interaction per se. Some cannabinoids, THC and more so CBD, to be honest, right? And so probably a lesser worry for something where you're kind of probably okay, it's probably a higher THC type of cannabis that you're using, and you're using it through an inhalation route infrequently, right? So when I think of kinetic or pharmacokinetic types of drug interactions, I'm usually thinking of stuff that competes for metabolism. So it does seem like particularly CBD could block some metabolic liver enzymes. And if you're taking other medications that were metabolized by those enzymes, then you could end up with higher blood concentrations of those particular kinds of drugs. Probably going to be way more of a concern, again, with CBD in high doses taken by mouth consistently, right? So, okay, inhaled cannabis that's higher THC on a really intermittent or irregular kind of basis is unlikely to introduce these kinds of drug interactions where you're going to really be boosting the concentrations of other medications a person's taking, right? But if you did do that, like boosted the concentrations, then you may run into more side effects or adverse effects related to whatever medications they were taking, which is, sky's the limit as far as like filling in the blank of like what those kinds of effects could be.
Okay. So,
I think sometimes you get maybe like you get combinations of substances that start to tell you something about the person. Like for me as a pharmacist, like if I looked at a regimen, an application for whatever psychedelic experience really, and I saw an anti-cholesterol medication and 2 blood pressure lowering or antihypertensive medications and a baby aspirin or an antiplatelet medication and a blood thinner or anticoagulant medication, all of a sudden that screams, I've had a heart attack, this is post-stroke, this is a heart failure regimen. Though when you get different classes of cardiovascular drugs that are used in conjunction with one another, it may not be so much as what's the drug interaction between those cardiovascular meds and cannabis or whatever psychedelic, and it comes a lot. It kind of comes back to, well, the elephant in the room is the underlying cardiovascular condition. Now, inhaled cannabis, I don't think of as necessarily having a high level of cardiovascular risk to it, but if you really look hard enough, you can find some persons that have had a myocardial infarction because of some of the heart rate increases that could come along with it. So, I mean, that would be a pretty fragile cardiovascular situation, right? I don't know where you draw the line and say that's contraindicated versus that isn't, right? But I'm saying like it would have to be a pretty fragile kind of cardiovascular situation before I would have like a real level of concern for cannabis. And then I think similarly, like mental health related things is like, okay, maybe there isn't like a huge amount of drug interaction between this antidepressant and benzodiazepine and mood stabilizer. I mean, there could be, again, if you're taking high doses of oral cannabinoids and things, there really could be drug interactions, but I'm kind of pushing that to the side because of the use case that you're sort of like talking about, where that seems less likely. And again, I would kind of look at it as like, well, man, like it seems like this person was prescribed these mental health medications for some sort of reason. Maybe it's overprescribed, maybe it's mismatched, maybe they're overdosed and they're getting side effects, and maybe they don't like it, and maybe they don't need it. But somebody at some point prescribed it and they decided to try it and take it. So it's just more of a surrogate marker that there's something underneath all of that. And if we start rocking the boat a whole lot and taking a bunch of things away, then we're likely to see something different. And maybe that will be withdrawal if we do it too fast. Maybe that will be a more severe kind of illness where we do start to maybe like worry about like the candidacy. Maybe if we taper slow enough, the person will feel a lightened side effect burden and they actually feel better as they go. Like tapering meds, when it's done correctly, and the person really doesn't need that medication, or they're done with their course of that medication. Maybe they needed it at some point. They've grown, their life's changed, they have different coping skills. Maybe they don't need it at this point. But basically, there's a way that I don't like it to, I feel like there's a lot of negative suggestion I put out there in the world around medication tapering and withdrawal and things like that. So I'm trying to balance it a little bit with, if it's a mismatch with the medication and the tapering is done at a slow enough rate, then it is possible just to feel better as you get off stuff too. Like it's not always yeah.
Good. Right. Well, that's a really good answer. So let me, if I summarize what you just said, is that, generally there's no direct contraindications between cannabis and other medications when used in the cannabis psychedelic experience that I communicated, which is vaping in a safe and setting. However, it is important when we're looking at an intake form to consider the general picture, the particular drugs that someone may be on, to their general health and well-being, and that if they are taking a bunch of heart condition related drugs, then we might want to consider being either saying no to that person unless we're qualified to deal with someone who may have a heart attack. Now, just to be clear, all of our facilitators, should have a first aid course and CPR course. But even so, even if you've only done one of those and you've never treated anybody, that might be a scary experience. If you're not confident as a facilitator, then it's probably best not to deal with someone like that and say, oh, sorry, it's just maybe not for you, unless we bring a doctor or a nurse to sit with them on that particular experience. And same with more the mental health issues. Again, if they have bipolar or suicidal tendencies, it's probably over the line where we say, well, this is probably not the best kind of therapy for you at this time, with our qualifications. And there may be other people that may be willing to deal with that. But generally, there is no contraindications for on a pharmacological basis with cannabis, which is great.
Yeah, I mean, like contraindication, I think too kind of comes in like in pharmacy, there's absolute contraindication where it's just black and white, like totally, and you're never going to employ those elements together because the degree of risk is just unacceptable under any circumstance, really. Whereas most things, when persons say contraindicated, are more like 50 shades of gray. So it's like recognize that, well, there is perhaps a higher degree of risk with this level of circumstance, but maybe there's something we can do to mitigate the risk. Or so I think a lot of this conversation, unfortunately, still centers around prohibition when we're talking about like risk. Like, I think that going to the Heart Attack Grill and getting a margarita with a double cheeseburger is probably worse for your cardiovascular health than going to a psychedelic or cannabis assisted therapy session, right? But one of those things is sanctioned and what you're supposed to do when you go out at night, and the other thing is not, right? So this conversation, I guess, could like a listener could kind of like hear this and sort of think, well, yeah, like while we do that, there's all of this like risk caught up here. And it's like we're talking about risk because I don't know, we had to, and that was like part of the question. But when you compare it relatively to the risks that are taken doing other activities that people don't bat an eyelash about, then it all of a sudden things become a lot more like you're saying, like what is the real contraindication? Like if you're going to ask me, Ben, Dr. Ben, what is the contraindications for eating double cheeseburgers?
Yeah.
Right? We'd probably be in a very similar space as far as like, well, if you're really obese and your heart was already clogged and you were taking some cardiovascular drugs and your doctor had told you about nutrition, you probably shouldn't, but will it kill you to have that cheeseburger? And if it was your dying wish or there was cheeseburger assisted therapy that had a massive upside or benefit to it as well, because that's the part we haven't talked about, is like what is the upside for people in medicine? Like you never consider just risk in a vacuum. It's benefit versus risk in the face of likely alternatives. And what are the likely alternatives? Pharmaceutical agents that are taken on a chronic basis, that do have chronic side effects, that do have overdose risk, that do have lethally defined doses to them. Man, intermittent cannabis use in a setting where you're going to make sure that psychologically they keep you safe, and the physical risk is fairly minimal to begin with. I mean, it's really like a prohibition conversation that we're having, unfortunately, rather than like one that is true, like bona fide, like let's just put all the options on the table and talk about their risks. Like frankly, it's like the risk is almost like sensationalized because of the illegality, rather than if you looked at it relatively, is it
Ah,
dangerous?
breath of fresh air to hear that perspective, Dr. Ben. So really appreciate that, especially from someone like yourself. So I think that's clear in there. So, but let me just talk a little bit more. I'll go, I know this is not what we're focusing on at Cannabis Psychedelics, but just for people who are interested in psychedelic therapy, because some psychedelics do have a high propensity for physical risks in combination with psychotropics, primarily with ayahuasca and ibogaine, though other combinations with other phenylalanines and ketamine can also have a significant risk. Classic tryptamine psychedelics typically are the lowest risk with psychotropics. And I believe that medications in which tapering may be particularly reasonable including all the GABAergics such as benzodiazepines and Z-hypnotics, gabapentins, pregabalin. Sorry, I don't know all these names really easily to say. And even sleep aids like trazodone, etc. Is that the general overview of psychedelics and psychotropic challenges? Again, I'm just trying to focus on the contraindications. So just so people are aware, it's not what we do. It's not what we're, here to teach people.
Yeah.
You're an expert.
Yeah, sure. So I do think like as far as like medical risk of a psychedelic, well, I don't know, there's hundreds of psychedelics out there, but the common ones, the popular ones that people are like kind of seeking at this point in time, I do think ibogaine is probably the highest because of its like cardiotoxicity or kind of like arrhythmia risk. So when a person is just sort of, well, I want to try a psychedelic, and I haven't tried many psychedelics, so maybe have garden variety, vanilla, low grade depression. Should I go for ibogaine? It's like, I don't know, for like a psycho spiritual, very light mental health type of thing where you haven't tried other psychedelics before, I'd probably be reaching for something like psilocybin to begin with, or psilocybin mushrooms, where if it was more like, well, yeah, I have an addiction to heroin or cocaine, and I have been to rehab a couple of times. It didn't work. I've been revived a couple of times. I actually should be dead. And, I've tried methadone and that just didn't work for me. Can I try ibogaine? It's like, well, yeah. I mean, because I think for the risk that you're taking, the benefit is comparable, or if not in your favor. And you've tried a lot of the likely alternatives and they just haven't panned out for you. So again, from that risk benefit angle, it makes a lot of sense for certain people to try psychedelics that might have higher levels of medical risks or risk of arrhythmia like ibogaine, whereas for others, it's not going to make a whole lot of sense, at least initially, right? Ayahuasca is actually a pretty safe psychedelic, like overall. It just, the monoamine oxidase inhibitors create a metabolic vulnerability to certain other types of drugs or foods. So ayahuasca can actually be done in an extremely safe way, just so long as a person is aware of the types of interacting drugs or foods, and they are tapered if it's medications, or just avoided if it's food. But I don't necessarily think like if you're not taking the interacting medications or drugs, and you're staying away from tyramine in your diet, I actually don't feel that ayahuasca is really much, or maybe even any more medically risky than something like psilocybin mushrooms. But it does create the metabolic vulnerability, and there's more to know about drug interactions and things. There's more to avoid, I guess. But as long as you avoid it, it is very safe still. And then, yeah, I agree with you. You have things like ketamine and MDMA that are okay, they're relatively safe still, but particularly MDMA, I mean, it's a designer amphetamine. It follows a very traditional toxicology profile. Okay, some people have popularized taking big doses of mushrooms. It's like a hero dose or something. You don't be a hero with MDMA. Like, please don't. I mean, don't be a hero with psychedelics anyway. It's like this macho thing. You don't need it. You need a high dose because you want to go there. Okay, that's a high dose, but there's no like medal that you're going to get. You're not like going into a burning building to rescue a small cat or something by having a big dose of a psychedelic. Like, I kind of get rid of that terminology. Uh, and I don't know, like they also have a little bit of habituation and addiction potential, I would say, like ketamine and MDMA. So maybe depending on your issues, like if I had somebody that was coming from cocaine use disorder, amphetamine use disorder, or maybe just had an Adderall prescription that got a little out of hand a few years ago, and they just said, I don't want to touch stimulants really anymore, I probably wouldn't be leaning towards starting with MDMA or something like that for them. I'd probably be going way more the classic tryptamine kind of route. Um, so yeah, there is a little bit of a hierarchy of, I think, like physical risk that you outlined like pretty well, with ibogaine being the top, ayahuasca plus or minus depending on the interacting kind of like stuff, psilocybin, LSD the lowest, and then yeah, MDMA and ketamine, still relatively safe drugs as long as you're taking the sorts of like standard doses, but you start mixing it with other stuff, you start going outside the normal dosing ranges, and there is potential for adverse physical stuff. Yeah.
Very cool. Do you have any experience with long-term issues? Are there any long-term issues with microdosing any of these drugs, particularly psilocybin, LSD, ayahuasca?
There's definitely some theoretical things out there, right? So, for example, all of those psychedelics that you mentioned bind serotonin receptors. There's many types of serotonin receptors. We think the serotonin 2A receptor is kind of most critical to psychedelic mechanisms, but they all bind to serotonin 2B receptors. Serotonin 2B receptors are found in heart tissue, and they are linked with valvular heart disease when taken chronically. So you use mushrooms in high doses intermittently, you're never ever going to see any kind of chronic toxicity from that. But microdosing, if it was done frequently enough and long enough, maybe you would see that kind of chronic toxicity. I have not come across cases of persons microdosing that have this yet. I have come across cases of persons that use MDMA weekly for like a decade and do get like a valvular heart disease. There have been other drugs that have been pulled from the market over the years. So fen-phen was a dietary drug in the mid 90s, and fenfluramine was the component that was removed. That's a phenethylamine. So I don't know. Psilocybin is not a phenethylamine. It's a tryptamine, but MDMA is a phenethylamine. A few others that have been pulled are things like methosergide. It's an old school migraine drug. It's an ergoline. LSD is an ergoline, right? So we're really getting kind of in the ballpark. And from the sort of FDA's perspective, or like the FDA's expert toxicology panel on valvular heart disease, basically the strongest marker that we know of that can predict this is the affinity of the drug for the serotonin 2B receptor, and psilocybin definitely has the right affinity for it to be a risk. So there's absolutely no way that the FDA is going to be approving any kind of microdosing regimen without like some really hardcore trans echocardiography studies. And they did just, earlier this year, maybe over the summer, they released the FDA released a draft guidance document for industry. And they basically said in that draft guidance document that we don't even want you to include people in the large dose intermittent trials that have pre-existing valvular heart disease or pulmonary arterial hypertension until we are aware more of what this risk actually kind of looks like. So I don't want to be incredibly alarmist about microdosing because it isn't something that we've seen a whole lot, but I do caution people not to microdose for cycles longer than 2 or 3 months, to take breaks between the cycles, because if you're really microdosing every third day, every other day, 5 days on, 2 days off for 4, 5, 6 months, that is the sort of time frame and frequency of exposure that's been good enough for other drugs, at least, to kind of cause this valvulopathy. So with people, I really like the innocent until proven guilty kind of angle. With drugs, I like guilty until proven innocent. I like it that we assume it has this risk until it has been vindicated, or we have really produced the kind of the data to suggest that it like doesn't have that risk. I think moreover, I've also just met a few people. This is just more like anecdotal now, speculative, anecdotal observation kind of like stuff. I have met a few people that microdose on a longer term kind of basis, and thank God they've not came down with or complained of any valvular heart disease. But they've said that microdosing turned on them at some point. Like it's sort of like 2 or 3 months. It's like the first 2 months, it was nice. My anxiety was less. I was more focused. And then it started making me all wiry and agitated. And I took a break for a few months and reintroduced it, and it was nice again. I don't really know why this is, but I've met at least a half dozen people that have like reported this kind of like pattern, and you can make up all sorts of psychospiritual interpretations for why that could be. I don't really want to get into it. But
So,
yeah, those are my thoughts on it. Yeah.
So for people who I mean, around here, I've heard a lot of people, again, anecdotally consuming microdosing of psilocybin, particularly 2 or 3 times a week for years, literally. Is there something that they should check? They go to the doctor and say, hey, can you check whether I've got valvular heart disease? I don't think that's a general question you go to the doctor, is it? Or...
Yeah. No, I mean, you don't, but you could. I mean, you could say like, hey, can you do an echocardiography study and measure my heart valves? I mean, you could like ask for it to be monitored specifically. I don't have at the top of my head, maybe there's one in Australia, but I know the American Heart Association basically just has like a symptom checklist page, right? So I'd probably like kind of like, well, first of all, if I've been really microdosing for years and years and years, I might just sort of like, hey, why don't I just take a break to like a month and just kind of reflect and like see who I am without the microdosing. It could be a reasonable thing to do, particularly because microdosing shouldn't really have much in the way of like a withdrawal syndrome or like a problem stopping a big crash or things like that. So it's feasible to take the break. But yeah, I guess like, okay, you're not having symptoms. I don't know, honestly, I think like if it was me and I'm curious about this stuff, I think if I was microdosing and I was planning on really going for months and months for whatever reason, because nothing else works, because this is amazing, because whatever, you've got a good reason. I think it is something that I would go ask for to have my heart valves measured. I would go and like, hey, can I do some echocardiography once a year just to check in? And then if I got symptomatic, I would stop and go do it again. Yeah.
Stop immediately. Yeah, I just know people who use it, just to enjoy going out and dancing or exercise or being in nature and find that connection regular. So
that's honestly like, in the spirit of just making up a micro dosing regimen and coining it with your own name, right? There's kind of like a twice a week Fadiman. There's a 4 days on, 5 days on, 2 or 3 out. There's like a Stamets. I would like, it would be, for me, it would be the PRN Perfect Sunday. PRN just means as needed. So instead of thinking of microdosing as like, it's a regimen for my mental health that I'm on this kind of like thing, and basically almost like taking the psychotropic model and making it as close to using psychedelics as possible is sort of like what it seems to me. I mean, you know, it works for people. Like I'm not trying to like knock it per se, but I think I've found in my experience that I'd much prefer, instead of being on a microdose, to talk to Paul on a Monday to podcast. And I'd much rather be at that, oh wow, I've got a day, might go outside, maybe I'm going to do some gardening, go for a hike, hit the beach. I'm just going to enjoy some kind of R&R activity. Like I would use it to augment a good day, to augment my hobbies, to right, to make the play of the day essentially a little bit more special, where when it kind of comes to like, you know, you get these consults, it's like, so why do you want to microdose? And it's kind of like, well, I'm burnt out and I need to increase my productivity.
Oh wow, yeah.
It's just kind of like, man, it seems like we're kind of shoving a square peg in a round hole here. And then almost it's like I took a microdose and it just made me fatigued, and like I took a nap, like no one told me, is that those side effects? And it's sort of like, it might be a side effect, or it could just be the mushroom showing you exactly what you need, which is deep rest. Like you're
Yes.
not depressed, you just need deep rest. Like you just need to take some time and stop thinking about life as about production all the time or something of that nature.
Mm. We're
Yeah.
going we're going to good subjects, but I want to come back a little bit more to the science side of things for a second. How does psychedelics impact the transmodal cortices of the brain? Is a question.
Oh, I know. You need a neuroscientist for the answer, right? So I'm a clinical psychiatric pharmacist, and my understanding of it, you know, is that you have these different areas of the cortex. So this is the most like outermost like area of the brain. This part in the front, the prefrontal cortex, is supposed to be one of the most recently evolved structures of the brain. Humans have a larger prefrontal cortex than other primates. And the cortex is, you know, picking up different type of like sensory information. So, you know, have like a visual cortex, you have like a somatosensory type of cortex, you know, audio, I think I said visual maybe already. So you have these kind of like what they call like unimodal like areas of the cortex that then integrate to transmodal, or kind of like higher areas of the cortex. So there's things like the default mode network, which is part of this, you know, medial and dorsolateral prefrontal cortex in a functionally connected circuit with parts of the limbic system, the amygdala, the hippocampus, the thalamus. There's also like salience network, so like meaning.
Mhm.
Human beings are kind of like story meaning making machines. Like they need that kind of like storyline and to place meaning different places.
This is a
So it
water
seems
bottle. It has water in it. If I'm thirsty, I will drink it. That's the meaning I have of that object. Yes.
yeah, yeah. So it seems like under the influence of a psychedelic, you get what they call like liberated bottom up content. So there's more information that is available from like the unimodal sensory cortex. So this might be audio, it might be visual, might be more like the vagus nerve, might be like internal, like visceral organs type of sensations. But areas of the default mode network are hypoactive or less active than normal. And these are essentially called like top-down control mechanisms. So it's like kind of your brain is as far as my understanding, it's like a pattern recognition type of machine. And you're getting this kind of sensory information that's coming in, and it's going through these association cortexes that are arranged in like hierarchical gradients. And then it is being interpreted and coming back down. Right. So, okay, I'm looking at something over here. It's kind of bright. There's this glass thing in it. Oh, it's a light bulb. Right. And it's like, I actually don't know that that's a light bulb over there. My brain's just telling me it's a light bulb because I've seen something like that before. And somebody told me at some point, like those are light bulbs. Like that's what a light bulb like looks like. But is it a light bulb?
Mhm.
Or is it cake? I'm just not quite sure. So it seems that the psychedelic basically shuts down parts of our sense of self, or like self-referential type of activity. It may change like the activity of things like the salience or like meaning making networks. So basically you're kind of getting a less filtered view of the world. There's more kind of information that's available, and the sorts of normal sense of self and normal kind of perception or like meaning making areas are affected in a way that you can maybe create a different sense of self or create a different meaning or perception to things that you've encountered previously, right? So there's an ability to lay down a new storyline or a new narrative about what maybe events in the past mean, what things in your immediate world that your perception actually like are, or what the kind of connotation of those things are. Maybe you have some kind of core belief that, I don't know, psychologically makes it so that the glass is always half empty. You have some kind of experience and you switch things, and all of a sudden the glass is always half full, right? It's sort of like the glass is the exact same thing, but your meaning making, your perception was changed or switched around it. So this is insanely complicated stuff that I don't claim to be like the world's expert on. I don't do neuroscience. It's actually really difficult to even like slog through and like read the types of articles that are coming out, but they are absolutely fascinating types of things. And yeah, looking at these sorts of models of cortical processing, right, is something that I think is allowing us to sort of see the common threads between things like serotonin-based psychedelics, glutamate-based dissociatives like ketamine, and you know, even like cannabinoids like THC. There's okay, they all act on these disparate neurotransmitter sorts of targets, but maybe where they converge is the ways that they are changing or affecting cortical processing. And not to say that they identically affect cortical processing, these different types of things, but there's a real ability to understand non-ordinary states of consciousness through this kind of like common kind of lens.
Wonderful. That was one of the best explanations I've had of neuroscience. Thank you very much. In a way that many people can understand. So you may not be an expert, but you understand enough to communicate really clearly. So I appreciate that, Ben. That's really wonderful. So while you're describing a complicated subjects, I've got some really weird specified terminology that I think I've seen some places that I think I would love you to explain also, which is psychoplastogens, entactogens, and psychosomatodelics. Three really unusual specific terminologies. Can you maybe explain the difference between those and any other strange words related that you may?
Sure. Yeah. Yeah. Well, I guess I'll like back up like just slightly, right? Because there's been sort of like a genesis in psychedelic taxonomy that's come, and maybe first discovered in the West, it was psychotomimetic. So like mimicking a state of psychosis from an observer's perspective. So nothing to do with the person that's on the psychedelic, just what does it look like is happening to an observer. Then we get to hallucinogen, which is a subjective sort of perspective, but it means to generate hallucination. And I don't know, what does generating hallucination have to do with reduction of symptoms of mental health? It's sort of like, it's difficult to get the full picture to really understand what a psychedelic is if you're thinking about it just in terms of hallucinogen. It's really myopic, looking at psychedelics with the blinders on, kind of. It's like, yes, they can cause hallucinations sometimes. To think that that's where the buck stops is what the drugs are is ludicrous. And you have psychedelic, it's like mind manifesting or maybe soul manifesting. It's an umbrella term, pretty good umbrella term, pretty decent. Then you have like empathogen and enactogen, I think was one of the words that you had. So empathogen is to generate a state of empathy. Enactogen is to touch within or to touch self. So particularly phenethylamine psychedelics, and I'll say like MDMA is the kind of real prototype there. They're known as enactogens or pathogens. So they're essentially self-knowledge and self-empathy generating drugs, maybe generation for empathy of others as well. So I think of MDMA or enactogens or pathogens almost like a psychedelic with training wheels. It doesn't seem to be a whole lot of hallucinogenic activity, and they're not necessarily known for putting a person very far out there, causing these kinds of like mystical, spiritual ego death kinds of experiences where the person may even feel like their consciousness died and they were in some kind of mystical state where they had merged with everything. MDMA is very much an hour and a half into it, 2 hours into it. They look at you, their eyes are dilated like a saucer. You know that the MDMA is working. And you say, I thought I was going to feel like I was like drunk or on drugs or something, but I just feel more like myself than I've felt ever. And it's like, right, because it's sort of you without the fear. It's like you've been disarmed, but you didn't get distorted. You didn't get changed per se. It's like the fear got reduced. Sometimes people call MDMA a heart opener. I think it's more of a fear reducer. I think if you reduce a person's fear, they're naturally going to open and be emotional and vulnerable because nobody is a bleeding open heart when you're really scared all the time. I mean, it just kind of, rather than thinking of it, it blasts a person's emotion open. Well, it really dissolves a person's, fear or avoidance types of mechanisms or structures, which allows them to get in touch with this deeper kind of self that isn't driven by fear. What were some of the other words? Yeah, so psychoplastogen or neuroplastogen. These are a few words that have come onto the scene, I would say, like in the last 10 years, maybe even more recently, maybe more like 7 years, something like that. And these are really exciting terms because they explain what psychedelics are through a biologic kind of lens or a neurobiologic kind of lens. So they're really the first terms that we've had for psychedelics that are not focused on the state they're mimicking to an observer or the state the person is subjectively experiencing. It's much more of a physically, what is it doing in the person's brain? It's causing some level of neuroplasticity, which can be called neuroplastogen or a psychoplastogen. And psychosomatodelic, I don't know. I don't know if this is a good term or not. This is kind of a word that I've been thinking of because what I have noticed, and I'm not the first one, there's many, many other persons. In fact, I'm just sort of like building on what other people have really noticed is that a lot of the time when a person uses a psychedelic, it's like the default mode network, their sense of self is reduced, but then it's like their body takes over and starts acting out something. It needs to make some certain sounds. It needs to go into some certain position. It needs to make the Darth Vader breathing. It needs to gag energetically. It needs to shake. No, it needs to grieve in a whole body heaving, kind of like sobbing, crying kind of way. So it seems that emotional catharsis and somatic catharsis, like emotional catharsis through the act of the body, is a very, very common piece of a lot of psychedelic experiences for persons. There have been very famous psychedelic doctors that have come before me. Stanislav Grof, for example, talked about the inner healer that's activated through the psychedelic experience. So I thought psychosomatodelic, I put it out there, and a lot of people really like the term overall. I got a few people that were kind of like, that's a very long term and it's kind of like complicated. I got a few people that were like, why not just somatodelic? And I was like, oh, okay. I got one person that was both a physician and a JD, and they said they thought it was a very short email. They said it was a pejorative term because everything is psychosomatic. And sort of like, that's fair enough. Like I thought that was like a fair enough like criticism. So psychosomatodelic isn't really like a word that is out there and people are using. I just wanted something that inherently recognized the effects of psychedelics on the body and the body's role in the psychedelic experience. And it seems like mind manifesting kind of leaves that out in some ways. And there's such a focus, right, on the the serotonin 2A receptor in layer 5 pyramidal cells of the prefrontal cortex. Yet the serotonin 2A receptor is the most common serotonin receptor. It's found throughout the entire body. It's found in immune tissues. It's found in endothelium lining your blood vessels. So maybe there's more to it, and maybe we should be like, it's like a lot of theories of psychedelics are very trauma centric. You sort of have this idea that, well, a lot of mental illness, substance use, even physical illness is rooted in adverse childhood experiences or rooted in traumatic experiences that occur during childhood. And now there's this body of literature talking about adverse childhood experiences and trauma. And probably one of the most famous books, if not the most famous, is called The Body Keeps Score. It's like by Bessel van der Kolk. So, if the body keeps score, a psychedelic helps the body speak more. Like it allows the person to understand what their body wants in a way that is much louder and clearer than usual. Because I don't know if you're anyone out there is a little bit like me, you tend to be a bit cut off from the head down. You tend to be in the intellectual world a lot of the time, and sometimes it can be very difficult to drop into our bodies and know what it needs. Or maybe we do know what it needs, but it's difficult to give it that attention when it needs it. We have certain levels of responsibility or obligation, and we oftentimes tell ourselves that we can't do that. I'm talking with Paul on the podcast, my back feels a certain way. I'm not going to do the particular stretch that is absolutely needed for it or something. But if you don't take the time at the end of the day to acknowledge what this body needs and actually do those things, it does tend to accumulate. And oftentimes people just get into positions where they feel totally lost to understand their body or what it needs. And it's like the psychedelic experience oftentimes really allows the body to say something pretty clearly.
Absolutely. And that's been totally my experience, particularly with my 5-MeO DMT experiences. My body has done things, that I've been aware of. Slashing around. I'm like, wow, I obviously needed that. And it felt like I was adjusting myself. Like it was like I was doing my own chiropractic. I was totally not in control of it. I was only just about aware of it. But, that was an experience where I go, oh, look, my body just needed to do that. And also, a number of the other experiences you shared, I've certainly had that myself. So I think they're great words to explain something that's far more complex than simply trauma informed, which is absolutely a key part of what we do. The trauma part of using psychedelics to heal stuff that happened as a childhood, and I do believe that's very real, for a lot of people still. And it goes beyond that, and I think that's what you're using these words to communicate. It's not as simple as that, and not everybody is the same and just has something that happened in their childhood. There's far more. So it's which is why I think these therapies are great for not just people who have trauma who are coming to heal something. I think it's also great for people who think they're well, and because I think everybody, to some degree, being a human being, has something to choose, in some form. So I think psychedelics can be really helpful for most people when they're ready to choose them, of course.
Yeah.
Is there
Human beings are really deep, complex creatures, and you don't have to be symptomatic with a clinical mental illness to feel better. You don't have to be symptomatic with a mental illness to learn something about yourself that can improve your life. And I think that's a lot of what psychedelics are about. They're about self-knowledge. They're about self-discovery. They're about experiencing yourself. They're about experiencing the world in an embodied kind of way, so that you know who you are and you know what you value, and you can just make decisions that improve your life so much easier when you know those things.
Wonderful. That's a wonderful way to end this excellent conversation with you, Ben. I really appreciate the work that you've done. And again, all the links for Ben are on the side. Please go and check out his blog, particularly his membership program is awesome, and I would highly recommend it.